Welcome to this mini lecture. My name is Annelies Klein-Hierenbrink and I'm going to talk you through a case study from the course Diversity and Equality in Health and Medicine. The case study is COVID-19 or the coronavirus. Why this particular case? Well, it's a very good illustration of the ways in which differences and inequalities between people affect how disease and health play out at the level of personal experience, research practices, and governmental policies. For example, just think about the ways in which this pandemic created discussion about who gets to live and who has to die when hospitals start to get full. Who stands in solidarity with each other during a lockdown, and who is seen as a threat or as an outsider to that solidarity. Who can afford to shelter in place and who is forced to go outside and be at risk. Who suffers financially and who even gets to make a profit. For this case study, however, I want to focus on a different specific aspect, the fact that health disparities between different groups of people have been observed. For example, the head of an ICU in Amsterdam observed that amongst his urgent care patients, people with a non-Western background seem to be overrepresented. The Dutch politician Geert Wilders, who is known for his right-wing anti-Islam politics, tweeted the following in response to that, and I will translate it for you. So treatments and operations of Henk and Ingrid with cancer, heart failure and other illnesses are being postponed again because our ICUs are mainly occupied by Mohammed and Fatima, who do not know our rule, who do not speak our language and who do not care about our rules. End quote. So here Wilders capitalizes on an otherwise important observation that COVID-19 strikes different groups at different rates. The observation from the Amsterdam ICU has been supplemented with data from other countries, including Norway, Sweden, UK, and the USA, where minorities all seem to suffer more from the infections. So for example, here we have some data from the USA, where we see that Native Americans, Black or African Americans, and Hispanic or Latino people have higher rates of infections, hospitalizations, and deaths, up to 5 times higher. So could it be, as Wilders suggests, that these groups of people simply don't care about the rules? Or could it be because, as we know, in all of these countries, minorities are more likely to work in jobs where working from home or social distancing is less possible, or that they're more dependent on public transport, that they live in smaller homes with larger families or in neighborhoods with poorer air quality, and that overall they receive less adequate health care. And that all of these factors also increase conditions like diabetes or high blood pressure, which in turn are also risk factors for higher COVID mortality. So is this really a cultural or ethnic issue, or is it a socio-economic issue? Now, our Prime Minister, Mark Rutte, condemned the tweet by Geert Wilders and pointed out that indeed the factors that I just mentioned are likely to explain the disparity. However, when announcing the measures and talking about the measures that the government is taking, Rutte mostly emphasized individual actions, repeating that if we all just stick by the rules, the lockdown is going to work. Of course, the suggestion that structural inequalities can be overcome by individual choice is a well-known hallmark of neoliberal government. And it's also a characteristic of a lot of contemporary health discourses which stress self-care and choosing a healthy lifestyle for yourself to ward off disease. That being said, it's important not to take these numbers for granted. One issue to keep in mind is missing data. In the US, racial and ethnic identity is routinely registered for patients in hospitals. But a lot of the data is missing too because the healthcare system is so underfunded that a lot of hospitals cannot afford to keep complete records. In the Netherlands, the situation is different. We have a different history. Talking about race is far less usual here. We tend to speak about ethnicity. And whereas ethnicity is used in medical research, a lot of hospitals do not register the ethnicity of their patients. It's legally possible, but it's considered controversial to do so. The concerns that are mainly discussed when there is debate about this include the privacy of patients and the possible misuse of data. But there are also more basic things to consider. How do we divide people into these categories in the first place? Because there is no agreed upon universal system to divide ethnicities. So for example, a person with Turkish parents in the USA is likely to be included in the ethnically white non-Hispanic group, the majority reference group you see in this table. Whereas a person with Turkish parents in the Netherlands would be registered as a non-Western minority. Now, in recent years, racial or ethnic health disparities have been studied from a biological, genetic point of view. And here the concerns become even more pointed. If we reduce the complex construct that race and ethnicity are to a biological phenomenon, this would obscure the way in which the very definition of these groups is socially and culturally dependent, and how structural social inequalities affect embodied health and illness. So, using race and ethnicity as medical categories may reinforce the very kind of us versus them thinking that impacts the health of minorities in a negative way in the first place. Now, another disparity that has been making headlines is one between men and women. Men seem to be dying from COVID-19 roughly twice as often than women. This too has been observed in multiple countries. And if we look at the news items, the one on the left remarks that men appear to be the weaker sex in this respect. The news item on the right links the health disparity to sex hormones. In fact, most news items reporting about this disparity frame it in biological terms. The idea that biological sex is a powerful predictor of health outcomes has received much attention in recent years. And this has been a response to the fact that in biomedical research, including drug testing, this has been done mainly on men and on male animals. And as a result, a number of prescription drugs seem to have been less effective in women and to have more side effects in women. To remedy this bias, there have been a lot of efforts in a number of countries to encourage or even oblige medical researchers to include sex as a biological variable, to test for sex differences in their data, whether they're working with humans or if not human animals. Even though the differences in these drug responses that have been observed are also due to social differences. Women tend to take more drugs, they're prescribed drugs more often by doctors, and they're more willing to report side effects. And even if we observe a sex difference, sex might not be the best predictor of a health outcome. For example, body weight correlates with sex and can have a greater impact on drug metabolization than sex itself. Nevertheless, sex is now looked at as the most important predictor of health outcomes. So you might have heard the phrase, every cell has a sex. Whereas women's health traditionally focused on reproductive health, now women's health is about the entire body, as sex is believed to affect every system and every organ. So here we see this principle on the site of Yale School of Medicine. So the notion that men are from Mars and women are from Venus, which has been rather anti-feminist, is now suddenly represented as the key to women's health being and to the new frontier of the feminist movement. Now, it is in this context that the disparity in COVID-19 is mainly framed in biological terms. At the same time, the disparity is discussed as a case in point why this biological frame is so important and necessary. See, COVID-19 has disparities between men and women. This means that sex is a very important biological variable. So there's a kind of circularity at work here, where biology somehow becomes the whole story. But is it? One example is the MERS outbreak of 2012 in Saudi Arabia, which also affected men much more often than women. And there, it turned out that the virus was transmitted mainly from camels to humans rather than from human to human. And camel handling in Saudi Arabia is mainly a male occupation. Nevertheless, several reports on the sex differences in COVID-19 are referring to the MERS outbreak to support claims that there must be an inherent vulnerability in the male body. So in retrospect, this difference for MERS, which was a cultural difference, is framed as a biological difference and used to support the biological frame for COVID too. So could biology be the whole story for COVID then? Again, we have interesting data coming from the USA. This is data from the Gender Sci Lab at Harvard, where they are tracking the mortality for men and women for each state. Now this graph shows that men are dying at higher rates than women. No group difference would yield a value of 1 on the vertical axis, and we see that all the lines are below it. But the size of the disparity differs quite a bit per state. In addition, and I will highlight a couple of states to show this, the gap has increased over time for a number of states, including Delaware, Maine, and Illinois. So there is variability in place and variability in time that suggests that we're not simply dealing with a universal biological difference. So which other factors could be at play? At this point, we have to speculate a bit. Perhaps gender stereotypes have something to do with it. A traditional gender stereotype is that men are less concerned for their health than women, that they respond to authority to a lesser extent, and that they're more willing to take a risk. In line with this stereotype, a recent poll has shown that men are less inclined to wear face masks compared to women. This is especially for men who consider themselves very masculine and who find their masculinity very important to their own identity. It's also increased in men who are politically conservative. Another possibility is to look at which data we're getting and which data we're missing. Due to the same stereotype I just mentioned, men are also less inclined to get tested for coronavirus. And in addition, women are overrepresented in certain professions where testing is done more often, for example, in hospitals. This means that mild cases will be detected more often in women than in men. And since mortality is calculated relative to the number of confirmed cases, this would make it seem as if women are surviving the infection more often and that men are dying more often. But this is just an artifact of the missing data that we have in men, or at least partially an artifact. So what is at stake here? Assuming that biology is the whole story, when in fact it isn't the whole story, could lead to a waste of resources or even misguided treatments. In addition, the emphasis on sex as a difference that divides us into two kinds of people can reinforce gender stereotypes that foster inequality between men and women, including health disparities. So there is a kind of circularity at work again. Although in this case, the notion that men are the weaker sex could have a very interesting effect on familiar stereotype, because it actually goes against the grain of men as being the more robust sex. So we've only touched the surface of this case study. COVID-19 is just the most recent chapter in a very long and very complex history where race, ethnicity, sex, and gender are used as medical categories. But we can already summarize a couple of insights. The first is that the size of health disparities varies with time, place, and also depends on the way data is collected and classified. Nevertheless, biological explanations are often favored, especially when it comes to differences between men and women. And this obscures the importance that cultural and social inequalities have and how they contribute to health inequalities. The same is true for governmental strategies that emphasize individual actions or the behaviors of certain groups. Here too, the importance of structural inequality gets lost from view. The stakes here are multiple. What kind of research is funded? What kind of policies are adopted? But also at a most personal level, what does it mean to belong to a certain group or to have a certain identity? This case study illustrates that health research doesn't simply discover differences or inequalities between groups of people, but it helps construct them. And Health Humanities helps us to discover how this process works and how we can deal with